Okay, so good morning, everyone. Thank you for the chance given to our group. And today we would like to present our student project entitled of Intestinal Malrotation. So this is our group members such as Puturati Dewi, Sian Luis Ong, Sintami Gema, Anastasia Quineth, Ayu Sari, Selin Aurelia, Aurelia Stefani, Made Bintang Dila, Putu Ardisa, Ayu Kurniati, Stephanie Violina, and Natasha Fratnya Devi. Now our presentation will be started from introduction.
I'm going to continue the presentations with chapter 1, introduction. I'm going to start this chapter 1 with background. So nowadays, between 1 in 200 and 1 in 500 live births have been estimated to present a condition called intestinal malrotations within the first 12 months of life. In intestinal malrotations, patients are an abnormally positioned duodenojejunal loop compressed by peritoneal latch bands obstructing the duodenum and the narrow fixations of the base of the mesentery, placing the SMA at risk of volvulus. In these conditions, the clinical manifestations that mostly appear were vomiting bile, drawing up the legs, pain in the abdomen, and abdominal distensions. And for the diagnosis of these conditions can be done either by upper gastrointestinal contrast series or CT imaging with oral or intravenous contrast. In symptomatic patients, arrangements should be made to proceed to surgical management by the latch procedure either laparoscopically or by laparotomy. Next is about problem formulations and objective. The problem formulations in our student project in this block was: first, what is intestinal malrotations? How is the pathophysiology and epidemiology of intestinal malrotations? What are the risk factors and clinical manifestations of intestinal malrotations? How is the imaging of intestinal malrotations? What is the differential diagnosis of intestinal malrotations? How to treat intestinal malrotations? And how is the prognosis of intestinal malrotations? For the objective, we have this point, and the first is to know about what is intestinal malrotations, to know about how is the pathophysiology and epidemiology of intestinal malrotations, to know about what are the risk factor and clinical manifestations of intestinal malrotations, to know about how is the imaging of intestinal malrotations, to know about what is the differential diagnosis of intestinal malrotations, to know about how to treat intestinal malrotations, and to know about how is the prognosis of intestinal malrotations. And the last is benefits. For academics, through these student projects, academics can have a better understanding about what is intestinal malrotations is. Academics will know about the pathophysiology, epidemiology, and how to diagnose the intestinal malrotations. Academics also know about how to treat the patients of intestinal malrotations. And for the practitioner, after reading the student project, practitioner will know more about what is actually intestinal malrotations is. Practitioner will have a better understanding about the definitions, epidemiology, pathophysiology, clinical manifestations, how to diagnose and how to treat the patients, and giving the preventions about this disease.
I will explain about the definition of intestinal malrotation. Intestinal malrotation is a congenital anomaly of the intestinal position that may lead to a dangerous complication called volvulus. Volvulus could happen on the midgut around the narrow base mesenterium. Intestinal malrotation usually occurs in the first trimester when the fetal gut grows and develops. Intestinal malrotation could be referred by an abnormal intestinal position, including the small intestine is located mainly on the right side of the abdomen. The cecum moves from its usual position in the right lower quadrant to the left of the midline. Narrow mesentery that has a lack of fixation, and also peritoneal bands called lead bands to pass from the cecum through the vertical right side of part of the duodenum.
I like to be explaining about the pathophysiology. Intestinal malrotation is a birth defect that causes the intestine to rotate abnormally during the fetal development, resulting in incorrect locations within the abdominal cavity. The midgut is orientated horizontally with the foregut to the right and the hindgut to the left during the 8th week of development, with a 90-degree counterclockwise rotations around the mesenteric arteries. The stomach re-enters the abdominal cavity and rotates 180 degrees counterclockwise during the 10th week of development. The duodenal jejunal flexure is positioned below and to the left of the mesenteric root, and the cecum is located within the right abdomen after a total counterclockwise rotations of 270 degrees. The cecum continues to elongate and descend during the remainder of pregnancy, eventually landing in the right iliac fossa. When the intestine returns to the abdominal cavity, it is also fixed. The ligament of Treitz secures the duodenal jejunal flexures to the left of the spine, whereas the cecum is secured to the right lower quadrant. From the treats ligament to the cecum, the midgut is attached to the posterior abdominal wall, preventing torsion around the mesentery and its vascular. Malrotations occurs when one or more part of the above-mentioned process fail.
I will explain about the epidemiology of intestinal malrotation. The incidence of intestinal or middle bowel malrotation is estimated at approximately 1 in 9,000 live births. The true incidence of intestinal malrotation remain unknown because most of the anomalies are asymptomatic. The worst case of intestinal malrotation anomaly is malrotation with volvulus. 30% of intestinal malrotation cases occur in the first month of life, 60% occur in 1 year of age, and 75% occur at 5 age of life. Intestinal malrotation in adult only occur in 0.2% to 0.9% of all cases.
Now, I will explain the risk factor of intestinal malrotation. Intestinal malrotation occurs in boys and girls equally. However, there are more boys that indicate the symptoms by the first month after birth. Most children with another health issues or defect have greater chance of having intestinal malrotation, such as heart defect, liver abnormality, spleen abnormality, digestive system abnormality, including gastroesophageal and intestinal atresia.
Here I'm going to continue to explain about acute midgut volvulus. A volvulus is a medical situation wherein the intestine twists upon themselves. Midgut volvulus can result in a blockage which could reduce of blood flow commonly because of a congenital anomaly known as intestinal malrotation. Common symptom of acute midgut volvulus is abdominal pain. They can be abrupt onset over hours or days, or chronic intermittent pain over weeks, months, or years. Other potential presenting symptoms, they could be intermittent vomiting, persistent diarrhea, malabsorption, or failure to thrive. The imaging of acute midgut volvulus can be done by plain abdominal radiographs and contrast examine. Plain abdominal radiographs show paucity of gas throughout the intestine with few scattered air fluid levels, and contrast examine shows incomplete rotation with an abnormally placed duodenojejunal junction, or DJ.
Now I will explain about chronic midgut volvulus. Midgut volvulus usually present acutely in the neonatal period. It can also be diagnosed after the neonatal period. However, it can be challenging to diagnose this after the neonatal period because the symptoms of incomplete obstruction due to chronic midgut volvulus may also be accompanied by mild symptoms. Because of this, after the neonatal period, malrotation needs to be included in the differential diagnosis. If the child has persistent or episodic abdominal pain, MESA, emesis, weight loss, or failure to thrive. The less common symptoms of midgut volvulus are intermittent diarrhea, constipation, hematochezia, malabsorption, bloating, and early satiety.
Okay, so now I'll explain about the acute duodenal obstruction, which is occur mostly in neonates but can also happen on adults. This obstruction resulting from extended lead bands towards the third portion of the duodenum, with the clinical presentation is often asymptomatic, forceful or bilious vomiting, gastric waves, abdominal distension, patient may look icteric and no signs of peritonitis or shock. The diagnosis can be done with CT scan with 80% of accuracy and a plain X-ray showing the sign of double bubble.
Next one is chronic duodenal obstruction. So the first one is volvulus midgut and intestinal obstruction, where it is the sign and symptoms of the obstruction, and it can lead into bilious vomiting. So next one, patient also have failure to thrive and intermittent abdomen. And on physical examination, abdominal distension and tenderness may be present. This is the imaging of chronic duodenal obstruction using plain radiography and ultrasonography, where the plain radiography, it is showing corkscrew sign, where the duodenal segments are dilated, and the duodenal junction is relocated due to the jejunum folding. And the second one is ultrasonography showing whirlpool sign, with rotation of the superior mesenteric vein around the superior mesenteric artery, which is typical for malrotation.
Today I'm going to explain about internal herniation. Hernial orifices can be congenital, including each normal foramina or recesses, and atypical apertures which were result from anomalies of peritoneal attachment and interior rotation. Or receive if prompted via inflammation, trauma, and preceding surgery, like gastric bypass for bariatric therapy and liver transplantation. Strangulating SBO is the most common manifestation of an internal hernia. It occurs after closed loop obstruction. Its clinical manifestation range from mild digestive symptoms to acute abdomen, duration, and reducibility of the hernia, and the presence or absence of strangulation and incarceration were associated as symptom severity. A palpable mass of herniated loops with localized tenderness may be revealed via physical examination.
The differential diagnosis of intestinal malrotation, especially in neonates, it's not divided as the adults ones. So the first one is neonatal bowel obstruction. It happens due to meconium pass failure in 48 hours. Next is neonatal sepsis, intestinal volvulus, congenital band, that is intraperitoneal adhesion that is unrelated to intra-abdominal process. Next, we have pediatric gastroesophageal reflux and intussusception. Especially, this intussusception may occur in older infants.
Right, now I will explain about the treatment and the prognosis of intestinal malrotation. Of course, if any of the emergency condition occur, then it has to be treated right away in order to return back the child into its normal condition or stable condition. And now the main treatment of the intestinal malrotation is through a surgical procedure. And now the main target of the procedure is to detect any volvulus or any obstruction. And now, in the case of volvulus, it can be treated by rotating back the segment in order to reduce the volvulus. In the case of the presence of any obstruction, we have to find out the main cause of it. Most of the time, it is by a peritoneal band extending over through the duodenum, making an obstruction in it. And now, the treatment of the obstruction is to be treated with ligation or reposition. And now, once the intestinal malrotation is treated, and we can ensure that it won't get back again, then most children experiencing the intestinal malrotation will also experience a normal growth in it. So the prognosis is good.
And now I would like to explain about the conclusion of this student project of elementary and hepatobiliary. For the conclusion itself, the intestinal malrotation is generally known as an anomaly of the intestinal position that may lead to a dangerous complication called volvulus. Volvulus itself could happen on the midgut around the narrow-based mesenterium. Intestinal malrotation usually occurs in the first trimesters when the fetal gut grows and develops. For the epidemiology, the incidence of intestinal malrotation is estimated at approximately 1 in 6,000 live births. There are also the symptoms and how to diagnose duodenum obstructions. The most common symptoms of chronic duodenum is bilious. The patient also have failure to thrive and intermittent abdominal pain. For the physical examination, abdominal distension and tenderness may be present. And the treatment of malrotation itself focuses on stabilizing the position of the intestine and recovering the function. If malrotation with volvulus or obstruction is suspect, consult to a pediatric surgeon immediately. I guess that's all from me. For the conclusion, thank you.